Assalamu alaikum and good morning. I am Dr. Sagia Afrose, Associate Professor, Department of Pharmacology, Bashundhara Ad-din Medical College. Today I am going to discuss about an important topic called dyslipidemia and drug used in dyslipidemia. Firstly, before going to the main conversation, I am going to define what is dyslipidemia. Dyslipidemia is a disorder of lipoprotein metabolism including lipoprotein overproduction or lipoprotein deficiency. There may be two types of dyslipidemia according to the serum level of the lipid. One is hyperlipidemia, another is hypolipidemia. But in developed countries as well as developing countries like us, the dyslipidemia are most commonly the hyperlipidemia. Hyperlipidemia disorder may be manifested by the elevation of the serum total cholesterol, low density lipoprotein cholesterol and triglyceride concentration, and as well as decrease in high density lipoprotein cholesterol concentration. But all the fats in our body are not the good fat. There are some bad fat and there are some good fats also. What are the bad fats? The bad fats are trans fats that increase the development of the atherosclerosis in our body. Now, how the bad fat develop the atherosclerosis? Atherosclerosis development এর জন্য bad fat responsible. Why? Bad fat transport the bad cholesterol from our liver to the peripheral tissue and thereby they deposit it in our vascular endothelium and produce the thickening and hardening of the arteries and production of the atherosclerosis. But good fats are the monounsaturated and polyunsaturated fatty acids like HDL, high density lipoprotein. They are good because they reduce the risk of development of atherosclerosis because they transport the lipid from peripheral tissue towards the liver and metabolize them. Now, what is atherosclerosis? In my previous slide, I am discussing about the atherosclerosis. Now, I am discussing about what is atherosclerosis. Atherosclerosis is the hardening and thickening of the arteries and it is a condition in which plaque formation or plaque buildup inside the arteries. The plaque is made up of cholesterol, fatty substances, cellular waste products, calcium and fibrin. We all know that fibrin is a clotting material in the blood. Now, what are the important risk factors for development of the atherosclerosis? Number 1, increasing age. Number 2, gender, especially the young adult male, but the premenopausal women are relatively protected. After menopause, the risk in case of women increase eventually. The family history, genetic abnormality, hyperlipidemia, hypertension, cigarette smoking, high level of the C-reactive protein, diabetes mellitus, obesity, physical inactivity, stress, postmenopausal hormone replacement therapy, high carbohydrate and high fat intake are the important risk factor for the atherosclerosis. Now, I am going to discuss about the types of dyslipidemia. There are two types of dyslipidemia, one is called primary, another is called secondary. The primary dyslipidemia is known as familial hyperlipidemia. Familial hyperlipidemia is even actually the genetic cause and the secondary cause of the hyperlipidemia or dyslipidemia are some medical conditions and some drugs. Which medical conditions are responsible for development of the secondary hyperlipidemia? The hypothyroidism, obstructive jaundice, Cushing's syndrome, diabetes mellitus, nephrotic syndrome, chronic renal disease, chronic alcoholism and certain drugs. Which are the drugs that are responsible for secondary development of hyperlipidemia? Thiazide diuretics, glucocorticoid, beta blocker, combined oral contraceptive pills and atypical antipsychotic drugs. Now, how we diagnose the dyslipidemia clinically? through clinical features. The important clinical features are premature arcuous senilis. It is the white and grey discoloration and opaque ring development in the corneal region. Number 2 is tendon xanthomata. This is the hardening and non-tender development and enlargement of the tendon, and it is mostly occur in the tendo-achilles. And xanthelasmas, it is the fatty deposition of the tissue under the skin of the eyelid. These are the important clinical feature which can define the dyslipidemia. Now, the investigations. Which investigation we usually done for diagnosis of the dyslipidemia? Number 1 is estimation of the serum lipid profile. The lipid profile typically includes the total cholesterol level, serum triglyceride level, serum low density lipoprotein level and serum high density lipoprotein level. Sometimes we also measure the cholesterol and HDL ratio also. The total cholesterol level in a lipid profile must be less than 200 milligram per dl. It is normal. The TG level or triglyceride level must be less than 150 milligram per deciliter, that is normal. The total low density lipoprotein cholesterol level must be less than 100 milligram per dl or per deciliter, it is normal, and HDL or high density lipoprotein level must be greater than or equal to 60 milligram per deciliter, it is excellent, and it reduces the development of atherosclerosis. Now, why we have the strong concern about the dyslipidemia? I am discussing about this. There is a strong relationship between the elevated serum cholesterol level and the development of the coronary artery disease, acute coronary syndrome, ischemic heart disease like angina pectoris, myocardial infarction, cerebrovascular disease like stroke, transient ischemic attack, some peripheral vascular disease, deep vein thrombosis, pulmonary embolism, etc., etc. So, now I am entering the pharmacology or treatment option of the dyslipidemia. What are the drugs that are usually used in case of dyslipidemia? The classifications of lipid lowering agents are: number 1, HMG-CoA reductase inhibitor. They are called statins. The drugs are atorvastatin, simvastatin, fluvastatin, rosuvastatin, pravastatin. The second group of drug is fibric acid derivatives or fibrates. The drugs are fenofibrate, ciprofibrate, clofibrate, bezafibrate and gemfibrozil. The next group of drug is bile acid binding resins. The drugs are cholestyramine and cholestyramine, and the next is cholesterol absorption inhibitors. The drug is azitimib, and some important vitamins like vitamin B3, niacin or nicotinic acid are also responsible for reducing the serum cholesterol level. So, we can use this vitamin as an lipid lowering agent. Now, I am going to discuss about the mechanism of action or role of statin in reducing the serum cholesterol level. How they act? They eventually inhibit the HMG-CoA reductase enzyme. This enzyme is a key enzyme for the biosynthesis of the cholesterol metabolism. Cholesterol metabolism competitively inhibit the conversion of the HMG-CoA to mevalonate by inhibiting the enzyme, and statin do this work, which is the rate limiting enzyme of the cholesterol biosynthesis, and as a result there is a compensatory rise in the low density lipoprotein receptor on the liver cell, and as well as increase the uptake and catabolism of the low density lipoprotein cholesterol, and thereby reduce the serum cholesterol level. What are the uses of the statins? Primary hyperlipidemia and secondary hyperlipidemia. Now, I am discussing about the adverse effect of the statins. Gastrointestinal adverse effect like nausea, vomiting, headache, sleeping disturbance, hypersensitivity reaction, and some abnormal liver function test like elevated level of the serum trans aminotransferase and elevated level of the creatinine phosphokinase, and thereby they also causes some muscle adverse effect like myopathy, rhabdomyolysis, myalgia and myositis. Now, I am going to discuss about the role of fibrates or fibric acid derivatives in reducing the serum triglyceride level. They acts as activator of peroxisome proliferator activated receptor alpha and also activate the lipoprotein lipase enzyme. Primarily, they activate the lipoprotein lipase enzyme and increase the degradation of the very low density lipoprotein and as well as lowering the circulating triglyceride level. This effect exerted by the activation of the peroxisome proliferator activated receptor alpha in the liver cell, in the fat tissue and also in the skeletal muscle. They also reduce the hepatic biosynthesis of the triglyceride level and also increase the fatty acid oxidation. What are the indications for fibrates? Prevent the episode of the acute pancreatitis, severe hypertriglyceridemia and raised triglyceride with type 2 diabetes mellitus. And the adverse effects are same as statin group. Now, I am going to discuss about the niacin. Niacin increase the synthesis of the lipoprotein lipase enzyme and reduce the production of very low density lipoprotein and increase their degradation and thereby reduce the circulating triglyceride level. Now, the sterol absorption inhibitor ezetimibe. Ezetimibe act by inhibiting the intestinal absorption of the cholesterol and reduce the absorption of both dietary cholesterol and biliary cholesterol and thereby reduce the serum cholesterol level. Bile acid sequestrants, they reduce the bile acid absorption and hepatic conversion of the cholesterol to the bile acid and increase the LDL receptor on the hepatocytes. Thank you all for your patience hearing